Welcome, everybody. We'll just give everybody a few moments to log in, and then we'll go ahead and get started. Thank you, everybody, for joining us today. All right. Well, I think that we've got plenty of people on the line now, and it's 8:01, so we'll go ahead and get started. At least it's 8:01 here in Boston. Thank you, everybody. Welcome from all over the world. Good morning, good afternoon, good evening. Thanks for joining us for our third and final session of our complex lower extremity trauma virtual education conference. Today, the topic will be femoral neck fractures, and we have a great agenda for you today. So next slide, please. Today, as I mentioned, we'll be doing femoral neck fractures. And just as a reminder to everybody, this is the third of 3 sessions. And we did pelvic fractures and acetabular fractures in the last 2 weeks. Those live sessions are recorded and available for free on YouTube. All of the pre-recorded lectures are available online for free. So if you're catching up, please, you can definitely go back and look at all of them on your own time. Next slide. Just as a quick reminder on Zoom, of course, just to keep things organized, please mute yourself if you're not speaking so that we don't have any unnecessary interruptions. It would be lovely if you could turn on your camera so we can see your faces. That's always much better than lecturing to a dark room. And then we do have the ability to have translated captions. So for those of you on the line today who, for whom English is not your first language, you can turn on closed captions, and you should be able to turn on the caption in your preferred language. It's through Zoom, and it's all done by artificial intelligence, so it's not perfect, but I hope it will assist in following along with the conversation. We do have faculty and HGOC staff on the line who speak multiple languages, especially French and Spanish. So if you'd like to post a question in the Q&A in the chat in your native language, we'll do our best to answer. But most of the discussion, all of the discussion today will be in English. Next slide, please. So just as a reminder to everybody who's joining us for the first time today, our course objectives, first and foremost, is to improve participants' knowledge of complex lower extremity trauma management principles. Second is to foster international discussion regarding orthopedic trauma care delivery. And then third is to motivate the younger generation of orthopedic surgeons practicing in low and middle income countries. It's really our honor and our privilege to participate in the training of really the future of orthopedics for those practicing all around the world. Next slide, please. So as I mentioned, my name is Kieran Agarwal-Harding. I'm the founder and director of the Harvard Global Orthopedics Collaborative, and I had the pleasure of sort of chairing the organization of this conference. Next slide. And with that, I will hand over to the 2 fantastic moderators for today's discussion, Dr. Shravya Challa and Dr. Haile Daniel, who are our chief residents, both going into trauma at the Harvard Combined Orthopedic Residency Program. So Haile, I think you're on the line. You can go ahead and take over. Thanks so much, everybody, for joining today.
Great. Thank you, Kieran. It's great to be here for the 3rd week in a row. We have a great topic and some really, really interesting cases this week. So very excited to get going with this this conference today. I just want to recognize some of the HGOC and SONA organizing team. They're really the brains behind all these conferences and really make everything run. So thank you to everyone, especially to Teja and Shravya and Sam, who have really been organizing this conference and made everything work. So our case presenters today are from all over the world. We have Dr. Arsène Ifrène from Haiti, Dr. Mohammad Khak from Iran, and Dr. Alazar Haile from Ethiopia. We have a number of case discussants as well who will be kind of facilitating the conversation and kind of guiding some of the teaching today. So we have Dr. Sami Haile from Ethiopia, Dr. Brian Madison from South Sudan, and then Dr. Pierre-Marie Woolley from Haiti. And then from the US side of things, we have Dr. Ken Rodriguez from here in Boston, Dr. David Shearer from San Francisco, and Dr. Mark Swinkowski from Minneapolis, Minnesota. This is kind of a suggestion of the agenda today. So we'll try and keep it within the time constraints. Obviously, if there's lively discussion going on, we may go over a little bit, but we'll start with Dr. Ifrène's case. He does have a recorded video, which we're going to play. We're having just some technological difficulties this morning. So we'll hold any questions. We'll play the whole video for that part, hold any questions till the end, but we'll be able to pull up some of the slides as we go through the conversation so we can look at x-rays and discuss them as we go. So I believe Tasia, I'll stop sharing my screen. I believe Tasia will pull up the video and so we can watch that to get this rolling.
For giving me this wonderful opportunity. As you can see from my screen, our topic will be about the femoral neck fracture management with limited resources. Our main goal will be to share our experiences from a clinical case based on femoral neck fracture management with limited resources. It was in February 2022. In our emergency room, we received a 23-year-old female patient with pain and functional limitation of lower extremity after a road traffic accident. To do the diagnosis, we passed to the physical examination. We asked the laboratory workup and imaging. In our physical examination, as deformity, we found left thigh in abduction, leg in adduction, and foot externally rotated. Left hip and thigh were painful when we palpated. The neurovascular field was intact. About the lab test, everything was okay. About the imaging, we just had this X-ray. And from this, we conclude a left neck and middle shaft femoral fracture. That means this patient has to be operated. But at this point, the main problem is about the hardware, because we added nails, even sign nail. So we discussed with our staff and we decided to use exactly what we had. And we will do it by Watson-Jones approach. Here, this is a picture showing the Watson-Jones approach, but in our case, we extend the incision laterally to expose the diaphyseal fracture site to expose well all the femur. After 72 hours from the admission, as we planned, we performed the surgery. This is our X-ray 1 day post-surgery. This is the first one, this is the second one. Physiotherapy was started after 6 weeks post-surgery and full weight bearing after 3 months. This is our new X-ray after 2 years, okay, where fractures are healing well and we have it necrosis of the femoral head. Now, let me show our outcome. This is our patient after 2 years post-surgery. Okay. 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 This is our patient after 2 years. Thank you. This is our hospital, Justinian University Hospital at Haile. Thank you so much.
Is not clear.
Thank you, Arsène, for putting that together ahead of time. Tasia, do you mind just pulling up the actual slides themselves? Because I think the X-rays were a little difficult to see because of the quality of the picture. Maybe we can have slightly higher resolution X-rays. And then Arsène, if you want to make some comments since you're live on the line, you can say a few words and then we can hand it over to Pierre-Marie maybe as well.
Hello. Good
Hi,
morning.
Arsène, we can hear you. Yep.
Yeah, I hear you. You hear me well?
Yes, we do.
Okay. Good morning, everybody. It's a pleasure for us to be with you. And what we gonna show from our presentation is using limited resources and try with the hardware that we have, okay, to give a good result. This is why okay, we want to show these cases. Okay.
Good. Hi, good morning. This is Ken Rodriguez from Boston. Arsène, could you describe what you saw when you did your approach at the neck? What kind of comminution, what kind of bony fragmentation were you dealing with? Because it's hard to see from the film whether the anatomy of the neck fracture was something that could be very challenging or not. What could you comment on that?
Yeah. I get a little bit comminution, okay, but we reduce well and we pass the 2 screws. Especially it was cancellous screws, 6.5. So a little bit communicative.
Good.
Arsène, sorry, Kira, go ahead. I'm sorry.
Okay. I was going to ask you, so if I could tell from your post-operative film, you used 2 screws at varying angles. Any particular reason why you chose that configuration versus the more typical 3 screws, the parallel 3 screws? That's what I was trying to sort out. Sometimes with the nature of the fracture, you have to make changes. But I was wondering if you could comment on your choice of screw positioning, whether you had to use one of the screws to reduce it and then you kept it. If you could comment a little bit on that.
Okay. First of all, at this time, we just had only these two screws, cancel screws available. But we just put one in the calca and the second one, we just put it just to prevent the shearing forces, okay? And with that, we after surgery we mobilize for a short time a patient, and this is our result. So we just do it because we just had this hardware available for this time, and the second one we chose this position only to one in the calca and the other one to prevent the shearing forces.
Thank you for clarifying that. So it was literally an issue of you only had two screws that could be applicable for this fracture, and you chose.
At this time, it was really difficult and really hard because we had at this time a lot of trouble in the country, and we had to do something for her. So that's why we use our hardware, what is available, to help her.
Thank you so much.
Thank you.
Arsène, did you have C-arm available?
No C-arm. We performed this surgery without C-arm. Okay, without C-arm.
Can you give us some advice on how you were able to get the screws of the right length? Because it seems like you did a really nice job there without getting the screws out of the head. Teja, can you go to the slide that shows the post-op X-ray?
Okay. Yep. We did it as I said without C-arm. Okay. As I explained, we perform by Watson-Jones approach. Okay, and we expose well the neck and the femoral head. Okay, we put this on traction. Okay, and we just put the screws. But the most important is to try, okay, to be sure both are exactly one in the calca and the other one to be in the position to control and to prevent the shearing forces, just like that. Okay.
And
But
yeah, that's a good case, and I think you did a lot of work to make sure that you get this reduction. Just a few comments regarding the fixation. You know, you had to fix the shaft first so that you get the a chance to pull on the reduction. I think that's what you did. The second comment is this kind of fractures. The most important thing is for you to get the reduction right, and I think you did well with going through a Watson Jones approach, but. Maybe one comment that I would like to add, because we've seen, I also work in a resource limited setting, and we have attempted to fix this kind of fractures using two approaches. First would be the anterior approach, direct anterior approach, just to have a good visualization of the fractures, especially if it's intracapsular, which I think is in this case. So you have an anterior window for you to get your reduction anatomic, and then use a lateral, either a percutaneous approach to get the screws in place. Sometimes it's difficult for you to get the accurate direction, the trajectory, and making sure you end up in a subchondral bone. But I think that's quite a good trick for this kind of fractures.
Yeah, Pierre-Marie, go ahead. Great comments, Brian.
Yeah, great. Thank you, Ifrène, for doing this. First of all, I want to commend him because he actually showed me this case after the facts, a couple months after, and he was telling me, what could have done better. I think that, given the limitation that he had at that moment, and I think one thing that wasn't mentioned is the window from the time of injury to the time of surgery. which was about 72 hours, if I'm correct, Ifrène?
Yeah, yeah.
It was 72 hours, which is
72
already
hours, yeah.
so they had to do something with as limited resources as they could, and I think they did a great job. One comment is going back to Brian's comment about Watson Jones versus the Smith Peterson approach or the anterior approach. I do both now. I'm more comfortable with Watson Jones because I was more trained in Watson Jones, and I'll tell you that you can have a really great exposure of that capsule, and you can have a really great exposure of that neck, you know, as long as you do the approach appropriately and not be afraid to extend it as much as you need to, keeping in mind the posterior vascular bundle to not go in the back. And one thing I really appreciate about this case is that he had 2 screws. And, you know, typically the basic would be three cannulated screws would be perfect. But, you know, if he had 2 screws, then that inferior calcal screw, you know, did the compression. And, you know, he thought about you can see there's a little bit of the perpendicular screw looks like it's going a little bit off the neck, or maybe it's close to it, the edge of the head, but it's perfectly well done. And I think he managed the case post-operatively well, so that he, you know, give that patient the best chances. I don't know if any of the other faculty would comment on this particular case, and you know, would they put the screw differently or any other type of advice for him?
It's hard to see. Are those fully threaded screws or are those partially threaded screws? What are can you tell us, Arsène? I can't see very well. So yeah, I'm trying. Obviously, this was successful. So it's hard to argue with that. I have to say I'm thinking whether I would have chosen to have this particular configuration and not even put just 2 parallel screws. I mean, we use 3 screws because it affords a little bit more control, right? In terms of angulation posteriorly and anteriorly, but I think this worked. I think I would have used 2 parallel screws, and I'm not sure if any other faculty would offer a different thought on that. But this worked nicely, I have to say.
I think one comment about the length of the screw, as I do a lot of them without C-arm, is, you know, I would agree that if you put 2 parallel screws, I would be more comfortable putting 2 parallel screws the same length if I had them. Because then if I put 1 screw and I'm sure I have a good compression on that inferior calcar, then whatever screw I'm putting next to it or close to next to it should be similar. And so I would more go to, if I only had 2 screws, I'd probably go parallel to it. I think one argument for him was the shearing forces, and I don't know if any of the faculty want to comment on that. Because I know there was a study out of it was sort of born out of Brown, I think, showing that, you know, there was really no difference in terms of, you know, that vertical, that 90-degree screw or that 3 cannulated screw, as long as you had the compression and make sure that your reduction was perfect. But I just want to hear other faculty's opinion about that.
Yeah, maybe we can pull in Mark Swintowski here, who gave the great pre-recorded lecture for this session on femoral neck fractures, talking about fixation methods. Mark, can you comment on the, first of all, the reduction? Because I think there's some comments coming in the chat that perhaps it's a little bit invarus, which I think is difficult to correct if you're, you know, don't have C-arm and stuff like that, and perhaps there's some comminution there. But also the configuration of the screws. Mark, can you comment a little bit on that?
Can you hear me?
Yes.
Yeah. Okay, good. So I think the reduction is really quite acceptable. With ipsilateral neck and shaft fractures, the pattern in the neck is often vertical. So if you have only 2 screws, I think what was done is really outstanding to have that second screw grabbing the inferior portion of the vertical neck fracture. I can't see it super well, but I do know that from analyses of a lot of ipsilateral neck and shaft that it's more often vertical than it is transcervical. So if you only have 2 screws, I think this is brilliant. The reduction is outstanding. The comment I would make about the exposure is if you don't have C-arm, it's much easier to use the Watson-Jones where you can see the whole neck, which gives you an idea about trajectory of the drill. Whereas if you're working through 2 incisions, you can't see the neck as well, and it's much harder to insert implants in the right position. The only question I have is, was the plate chosen for the shaft because you didn't have a signed nail? Because a retrograde signed nail would have been a great option, but this is really well done, showing priority for the neck fracture.
I think that Ifrène mentioned at the beginning that he didn't even have a sign nail available, which is why he chose to go with the plate.
Okay.
And one of the comments that's coming in the chat is the order of fixation. I just wanted to clarify that point. I think Brian mentioned it would be helpful to fix the shaft first so that you can then manipulate the leg in order to get a better reduction of the neck. Ifrène, is that what you did in this case? Did you fix the shaft first and then do the neck? Or Pierre-Marie in previous cases had talked in acetabular fractures about leaving the shaft so that you can mobilize the proximal femur in order to get better, control it with a Steinman pin or something. Was that similar in this case? Did you fix the neck first and then go to the shaft?
Yes. First, I work with the shaft. I fix the shaft first, okay, and after I go to the neck and I pass the screws. Okay, but the first one is the shaft because after fixing the shaft, I can reduce well the neck. Okay, so.
That's great. And then Pierre-Marie, you've talked to me about how when you do the Watson-Jones and you get good exposure of the neck, sometimes you use like a pointed reduction clamp to actually get the neck into that valgus position by clamping it at the superior aspect and getting a really good reduction. Can you talk us through that a little bit? I think it would be helpful for all the folks to know that.
Yeah, I mean, it differs case by case. I think every case is different. Every femoral neck you're gonna be doing is different. Dr. Rodriguez mentioned, what's the combination? Last week we saw inferior combination, and then there was a case with a superior combination, and so every case is different. With the Watson-Jones, the advantage is you depending on the way you do your dissection, you can have a really great exposure of literally everything and you can tag the capsule, you can see all, whatever neck, whatever combination. And so my process doing these through a Watson-Jones is, first of all, biology. I think we've mentioned this for the past 2 sessions. I've learned a lot from mentors who are here, like Dr. Swankowski, talking about, those posterior vessels, right? And so one thing, if you're doing the Watson-Jones, is do not go in the back. Regardless of whatever you're doing, do not go in the back. So my approach is do a more extensive incision, make sure I expose my neck completely, see my combination, and then, work from there. In terms of, reduction, you can use whatever you want. I've actually used a Weber clamp once or twice, depending on the combination. I've used, C clamps. I've used the reduction forceps. I've used pins. And you can use whatever you do, but I think what the best outcome for those fractures in literature, and I think people will agree, is what was published, which is your reduction has to be as perfect as possible. And I think that's what he got through this case. And so if you have the better your reduction, the better your compression, the better chances you have of getting these cases succeeded. But there's a bunch of comments on the chat about AVN. Yes, AVN is one of those big issues and non-unions, but most AVN is really, those are high, they're high numbers. And so there are other factors there that will contribute to that. But if you have a perfect reduction, I think you're doing something important. And the only way to achieve a perfect reduction is to clearly see what's in front of you and how to manage it. That would be my comment.
Thanks, Pierre-Marie. There are several comments in here. One great comment from Dr. Naresh Agarwal talking about the shortening of the neck. I think that Ifrène, you mentioned that there was some comminution, so it did have to shorten a little bit, right, when you were fixing the neck?
Yeah. As you know, we just had the X-ray, but we didn't see this before surgery. But when we exposed the femoral neck, we saw a little bit comminution, but we try to reduce and we fix with the screws. Okay, but it was a little bit comminution.
I guess there are a couple of questions raised, Kiran, in the chat box.
Yeah.
So one of them is using DHS to address both that you replied to. So I think in the absence of TR, DHS is not really a good implant choice where your tip apex distance cannot be controlled precisely in the absence of CR. So I don't think it's a good option. Rather, multiple screws would give you a better, reliable, better outcome in terms of, having a reasonable, screw spread as opposed to a single screw where you don't know, the tip is ending. So that's one thing. In the absence of the C-arm, I don't recommend to use a DHS. And the other thing somebody raised is 6.5 versus 7.3 screws. My experience, I don't know if there is any study comparing that. Maybe you can tell us, the faculty. But my experience is I have almost stopped using 6.5 screws for neck fixations. I like screws, and I almost universally use 7.3 screws these days, and I believe they hold better, and even two 7.3 screws in a narrow neck does better in my hands, and that's what my observation is. And I would like to hear the experience of the other faculty about that. And the third thing is, with available, two screws and the plate fixation, the only thing I could, add potentially is there is a bare bone exposed between the end of the plate and the inferior calcar screw. So that bare bone could have been breached, and you could use, a simple semi-tubular plate, which you can, use to bridge that gap. Just to minimize, the risk of fracture. But that plate does two things. It prevents the shear force. Though your inferior screw, your perpendicular Paul screw, is doing that. The plate also could do that better. And the second thing is, it minimizes your periprosthetic fracture possibility as well. Thank you.
Sorry, Sammy, you're saying to place the semi-tubular plate on the inferior medial aspect of the neck to prevent that shear force? Is that what you're describing?
No, laterally. So laterally, you see where you have hardware at the end of the plate and then the inferior calcar screw. Typically we want to avoid that stress riser area. We don't want it to be bare. If you have a fixation distally, if you put any nail, unless it is a thin nail, if you put any screw on the lateral side, you are basically increasing the stress riser on that region. So you have, two screws on distal as well as proximal. So if you want to minimize, the risk of stress fracture, you could, bridge it with a simple semi-tubular plate, which can do, two things at the same time, basically.
I think Haile had a few questions. Haile, you want to jump in?
Yes. So Sravia is on the line. She just is having some issues with the audio. She just had a question about if buttress plating from the Watson-Jones, obviously, limited in this setting, but if buttress plating from the Watson-Jones would be an option for this fracture pattern, if any of the faculty have thoughts on that.
Would that be buttress plating on the inferior neck or? what or on the shaft. I'm not sure.
No, I think they're talking about the buttress plate for the neck, Pierre Marie.
Yeah,
What's that?
So the only time I've done this and I showed the case, I think was doing a Smith Peterson approach. And I only did it honestly to learn, because there've been lots of thoughts about it. I don't think I don't think that it augments anything because you already have, I usually put 3 screws. And I think that's sufficient. But I've not done it through a Watson-Jones approach, and it would be very hard to do. It would be very hard. I'm not gonna say impossible, but it would be very hard to do that through a Watson-Jones. The other thing is you do it after you do your fixation, right? And so you have to kind of rotate the neck once you're done your fixation. I have mixed feelings about buttress plating. I don't know if any other faculty would want to comment on that as well, but that's a good question.
Yeah, my
we haven't
comment
heard yet from Dave. But actually, Mark, sorry, you were about to jump in. Why don't you speak, and then we'll hand it over to Dave for a comment.
just very briefly, Pierre Marie is right. If you're going to do a buttress plating, that's part of your preoperative plan. You really need to go to the Smith Peterson anteriorly because you cannot get the trajectory for the drill through a Watson-Jones.
Yeah, the theory behind it is for the really vertical fractures when you're trying to present some of that shearing that you can do this inferior buttress and with screws at the apex, prevent some of that, convert some of that shearing into compression. I think I did it a couple of times early in my practice because I was sort of trained more in a Smith Peterson type approach, and just it's a little bit of, even in a Smith Peterson, it's not the most straightforward thing to do. You have to kind of flex and externally rotate the hip after you do your fixation, and it's a bit awkward. And I'm just not convinced that it adds a lot of additional, I think, soft tissue biologic costs and an unclear, mechanical benefit. So I've gone away from doing it personally. But I agree that it requires the Smith Peterson if you're going to do it. I think well-placed screws and a good reduction and thoughtful placement of your screws is far more important than, using buttress plating.
This was addressed briefly, I think, earlier on about the sequence. And I think for this case in particular, the sequence of doing the shaft first and then the neck made a lot of sense, but just generally, obviously it's kind of an ongoing controversy when you're deciding which one to fix first. So if anyone has some thoughts on that or how they think about these when they come in, when you have these combined neck shaft cases.
Yeah, well, my thoughts is to do the neck first by putting an external fixator pin in the proximal shaft fracture. It's just much easier to manipulate with a shorter segment than it is with a whole leg. And the reduction of the neck is paramount. So that's why I've always recommended doing the neck first. But and another reason is if you're going to do a retrograde nail, it's good to have the neck fixed so you can decide the appropriate length. But I understand why it was done this way when you only have a plate. So I'm not being critical. It's just, in general, I think the neck should be fixed with the first priority with a pin in the proximal fragment.
Yeah, I think that's the key point, is that you have to have some control over the distal fragment, because obviously when the shaft is broken and you're pulling traction and rotating the leg, you're not getting any change of your reduction at the neck. So you have to do something to get control of the distal segment if you fix the neck first. But definitely the neck is the priority over the shaft. And it's nice, I think, if you know where your neck fixation is, to choose, if you're using a nail, which would be most common, getting the length of your nail correct when you know where the fixation is going to be in the neck. So I would agree with that comment.
I think one comment that was in the chat is like a lateral X-ray to look at the orientation. We haven't seen a lateral here to really look at the reduction, whether it's tilted anterior or posterior. I don't know if Ifrène has that X-ray to share. Maybe he doesn't. That's why we don't see it. But just wanted to put a fine point that that's obviously something that we should be checking, right? Like the reduction is paramount with these neck fractures. So making sure that that's done on all views, you can see that clearly. The other really fine point I wanted to put on from the chat, see this question a lot. The reason for the 2 screws, and Ifrène, you can clarify if I'm saying anything wrong here. The reason for the 2 screws in this orientation, you wanted that perpendicular screw to prevent the shear forces. That's why you put it in that orientation, but also because you had limited resources. You only had these 2 screws, and so this is the configuration that you had to go with rather than the typical parallel 3 screws going into the neck and the head. Is that correct, Pierre-Marie and Ifrène?
Yeah, it's correct. And I want to repeat the same thing. So we put the 2 screws. The first one will be in the collar, okay, and the second one just to prevent the shearing forces, okay. And we had we worked in a limited conditions with limited resources, so that's why we use this way.
Yeah, I think that's clear. Thanks. Oh, the other question I had for you, was the post-op protocol. So you kept this patient non-weight bearing, it sounds like, for 6 weeks, and then you started PT after that with partial, and then they only became full weight bearing at 3 months. Is that the sequence that you had?
Okay, as I said, after six weeks post surgery, okay, she began with physiotherapy, but we authorized the full weight bearing, the complete full weight bearing after 3 months. Okay, just to prevent other complications. Okay.
Well, I think your approach in this case was commendable given the resources that you had. The limitations obviously really forced your hand here, but I think the outcome speaks for itself. It's really remarkable what you were able to achieve with what little that you had there. Haile, I don't know if you want to have everybody just give final comments, and then maybe we can move to the next cases. But that was really great.
Yeah, absolutely. That was a really great discussion. If anyone has any final comments, we are running a little behind schedule, so we can go through those quickly, and then we'll pull up the next case.
Excellent surgery. That's my comment.
Thank you.
Great outcome.
Thank you.
All right. Dr. Mohammad, why don't you go ahead and share your screen and we'll go through your case.
Okay, yeah, thank you very much. Okay, good morning, everyone, and thanks for the opportunity from the FGOC committee for me to present my case. My name is Mohammad. I'm an orthopedic surgeon from Iran, now doing some research years at VIDMC Howard Medical School. I'm going to present a case of femoral neck shaft non-union from my early independence practice in a limited resource setting. Just to let you know, in my country, you enter the medical school after an entrance exam, and the government pays for your whole studies, the fees, and you need to give back to the community for 2 to 4 years after that by working in some resource limited settings in the country. So this is the case from my early practice. It was a 21-year-old man with multiple fractures, fixed nine months ago in the same setting with multiple plates and screws. And now the patient came to my office with limping, severe pain, and 9 months of non-weight bearing using 2 crutches. The knee was severely stepped with less than 30 degrees of range of motion, and the patient was opium addict, said that was after the accident due to the pain. In further workup, the inflammatory markers were well, and the incision from the previous surgery was not remarkable. So let's take a closer look at the fracture and the fixation. In cases where both femoral shaft and femoral neck fractures coexist, there is a general expectation for the femoral neck to undergo union. But here, as you see in the radiograph, while the femoral head is not in varus, there's a shortening of femoral neck apparent from these screws pulled out from the lateral wall. Also, I had a challenge here in the femoral shaft with a malreduction and kind of non-union. So I was having a patient with the femoral shaft malunion and non-union, a limited knee range of motion, and a potential femoral neck non-union, and a patient who was exhausted of 9 months of non-weight period. I was thinking of doing femoral, a subtrochanteric femoral osteotomy for the non-union. I could see in the femoral neck that was most probably case. I needed a device to help me reduce the femoral shaft malreduction, and also to bridge these screw trajectories, not to propose the patient for future pre-prosthetic fracture. So I decided to use distal femoral nailing. For the subtrochanteric osteotomy, I would need an angle blade. And also, I was thinking of doing a kind of quadriceps plasty after removing the plate from the shaft. I didn't have an angle blade at the setting I was working. They told me there's no access to angle blade, so I decided to use a DHS system for fixing my subtrochanteric osteotomy. For the distal femoral nailing, they told me that there is only short nails and they lack the full length of the nail. So it was fine because I could always bridge the end of the nail with a longer side plate. The other problem was that I just didn't have a fracture table, and my C-arm just could give me an AP view. I was not going to get into trouble with the lag screw going out of the femoral head. So I decided to use this screw as the trajectory I was going to insert my guide pin inside the femoral head. And when I measured the angle between this screw and the anatomical axis of the femoral of the femur, there was a 120 degrees angle between these two. So I was thinking that if I use a side plate of 135 degrees, I would do a correction, a valgus osteotomy of 15 degrees, which was quite fine for my case. So I had a femoral shaft malunion, non-union. I decided to use distal femoral nailing system. I had a limited knee range of motion. I decided to do a quadriceps plasty. I removed the plate and did a capsulotomy, released the quadriceps from the femur. It was kind of a Jude quadriceps plasty. I released the lateral head of the quadriceps from the proximal incision. I had a potential femoral neck non-union, so I decided to do subtrochanteric osteotomy. And this way, because I could bridge the whole femur, I could put the patient on an early weight-bearing status. That was fine for me. During the surgery, I inserted the lag screw. Of course, I used other pins as anti-rotation to keep the femoral head in place. After placing the lateral side plate, I could see you can see that I had 15 degrees correction. I didn't have access to oscillating saw, so I did my osteotomy using hammer and osteotomy drill bits. It was not a beautiful osteotomy, but I was happy that I didn't shatter the medial cortex, and it was fine for the setting I was working in. So I had a short distal femoral nail that could perfectly correct my reduction. I had my osteotomy here and a bridge between the distal end of the nail and my side. It went well with the patient. 3 months later, the patient sent me a short film of himself riding a bicycle with good range of motion in the knee, no pain, and he was just a self-trained mechanic going back to his work and was satisfied with the situation he was. The good news in resource limited setting is that the patient goes to work and you never see him again for 3 or 4 years. That means that he's okay. So I didn't see the patient for almost 5 years, and after 5 years, he came back to me with this imaging. There was a good union at the femoral shaft fracture site. My subtrochanteric osteotomy was united well, and femoral neck fracture was healing very well. The only thing was that the patient had a little bit limping, and this was the reason he came back to me. And as you see, there's signs of femoral head avascular necrosing beginning here. Fortunately, the lag screw was yet in its position, and the acetabulum was very fine. So I decided to remove the devices, preparing the patient for most probably future total hip arthroplasty. This way, I gave the patient, I think, 5 years of less pain, a good union at the femoral shaft fracture, and by removing the devices, I gave him a few more months for the screw trajectories to fill in, and the patient to decide to go to total hip arthroplasty. It's not going to be an easy total hip arthroplasty, but I think the whole procedure we went through was worth doing that. Thank you for having me here.
Thanks, Mohammad. Fantastic case. Very interesting. Any comments from the faculty?
Oh, I'll start by saying that proper pre-op planning works anywhere in the world. So congratulations. This is truly a remarkable result. Primarily because you were very thoughtful about what your plan was going to be, and recognizing the elements that you had at your disposal and those that you didn't, you compensated with a very well thought operation. And that's just an excellent example of when planning can account sometimes for lack of resources. Well done.
Thank you very much, Chair.
I agree completely. The only tip I would offer is if you are in a situation where you don't have a saw and you need to use an osteotome, you can make multiple drill bit holes along the same plane of where you want to have your osteotomy, then use your osteotome. It's a lot more controlled and will give you the exact orientation you'd like. But excellent planning, excellent surgery.
Thank you very much, Mark.
Brian, Pierre-Marie, Sammy, any considerations from your side from seeing probably a lot of cases like this?
Yeah, this is a great case. Using the dynamic hip screw system to do the valgus osteotomy, you could have used a blade plate or anything like that, as long as you do the same principles. One thing I want to say is that you've given that patient time, right? He's young, you give that patient time to kind of deal with those injuries, knowing that he's going to probably get a hip arthroplasty eventually, hopefully, if he has the resources. But that's been really well thought of, and it's just great. One thing I do as well is just take that DHS and flip it 90 degrees up, so you can actually see, have a better control. Because I don't know if it's lateral to where you're doing your osteotomy on this picture, but oftentimes I'll just put it on top, right? And then so you have where you're doing the osteotomy over your lesser trach. And then, as Dr. Sronkowski mentioned, you can do small drill bits and then just control that until you get to that medial cortex, and then just flip it over with a clamp or something like that. Great case.
Yeah, thank you for your comments.
Wonderful case, Mohammad. I think you did a lot of, you gave this chap a good chance again, and I'm sure he's very happy. Setting, of course, DHS available, but angular blade play is what we call the workhorse, and so I was just a little bit surprised that you were not able to find an angular blade plate, because in our case we'll have an angular blade plate in our disposal, but not a DHS. but it's a good job that you work with what you had at your disposal. And I really liked how you overlapped the DHS with the retrograde nail, because that helps with the the creating that stress riser, and it's a good technique. You can be able to maneuver the screws through as the screws for the side plate, so that they don't interfere with the retrograde nail. But overall, a good job.
Appreciate it.
How did you manage to do your interlocking screws? Do you have interlocking screws there for the nail? It looks like it. How did you do that without being able to do fluoroscopy in a lateral position?
For the distal, you mean for the knee?
No, for the proximal interlocks for the retrograde nail.
So we usually have those jigs that connects to the distal of the nail and goes back to the proximal, so we can find it. I mean, we are a complex setting of resource limited and full access to some stuff. So you can find some stuff there, but you cannot find the other. As he said, I didn't have the angle blade, but I could find it just from a nailing system.
It sounds like the nail was a bit like a sign nail. It had that long target arm.
I didn't really know what science system is before attending these lectures here, this meeting. We do not have access to sign in my country, I think. So this is not the typical sign nail, is it?
No, but the method, basically the sign nail just has that long target arm, so you can get those far interlocks. So it sounds like that's sort of what you had here.
Yes,
so that's great.
Exactly.
That's great.
We had one question from the chat about the distance between the DHS hole and the osteotomy site.
So using it for hollow screw side plate, I'm using the first screw here, as I remember. I used the nearest screw that could be fixed near the osteotomy site.
Thank you. And then one question I had was patient's activity level after. Do you restrict their weight bearing after doing the osteotomy?
So using a full length device and having the heater screw and the nail both together, I could put the patient on a weight bearing status the day after. Of course, the patient was having kind of high grade of pain, so he was not willing to cooperate. But after a while, I can say after 2 weeks, he was walking using the crutches. I tried to manage him with partial weight bearing for 1 month with 2 crutches, then another month of full weight bearing using the crutches. And after that, he was doing well. As you see, when he was riding his bicycle, it was 3 months.
Great, thank you. Yeah, he looks 3 months. That's amazing at 3 months what he was doing.
There's a question on the chat about blade versus the DHS. I from a biomechanical standpoint, would any else want to comment about what would be best if it's basically the same, or
Well, ideally, if you have a world where all implants are available, I would prefer a blade plate. I think you get the same amount of control with less removal of bone. But I have not been critical at all of this decision. I think it worked out great.
I was just going to comment too. I mean, it's such a great case example of the power of the valgus osteotomy. The principle is that you're converting, a more vertical fracture to something that's more horizontal, gets more compression instead of shear. The classic teaching is you're supposed to correct, the Powell's angle to like 25 degrees. But there are studies showing that really you don't need to do that degree of correction. I think this is a nice example of how just a small change to the mechanics, in this case, only 15 degrees. If you do the math, a lot of the, really vertical fracture, a 70-degree one would require really, aggressive osteotomy, but even smaller osteotomies, 20-degree osteotomies, or in this case, 15, really, shift the biomechanics in your favor. So I think there's just a nice example of that, and they don't distort the anatomy of the proximal femur as much, I think, which is nice when thinking about what might come next for this patient as well. So nice case.
Yeah, I think really nice case. Just for the purposes of time, are there any other comments, or I think we've answered all the questions in the chat. Should we move on to the next one? Great. Alazar, go ahead if you'd like to share. Thank you, Mohammad. Excellent case. A lot of good teaching points there. Thank you so much.
Thank you very much for having me. Yeah, thank you.
Am I visible, Kieran?
Yep, you're visible, and I can hear you perfectly. Go ahead.
All right. Thank you very much for giving me this platform to present one of our cases. I'm Alazar. I'm a final year orthopedic resident from Addis Ababa University in Ethiopia. So I have a case of a neglected femoral neck fracture for whom we did valgus intertrochanteric osteotomy, similar to the case presented earlier. Upload disclosures. For the case presentation, we had a 35-year-old male who presented to us with the inability to bear weight and left hip pain after he sustained a ground level fall while he was trying to rise from his toilet seat 6 weeks prior to his presentation. Originally, he is from the southwestern region of Ethiopia, and he was diagnosed with a case of neurolaterism, which results in spastic paraplegia at the age of 10. Following which he had bilateral limp and need of walking assistance to get by. He also had another family with similar gait problems, and he used to work as a shoe shiner, where he sits for a prolonged duration of time. So coming to the physical exam, he had a shortened and externally rotated left lower extremity with a positive log roll. Distal neurovascular exam was unremarkable. Both clinical as well as sonographic evidence for DVT were negative. So this was his pelvis AP X-ray, which shows a displaced transcervical left femoral neck fracture with sclerosis of the fracture end. So this tells us that this is an old fracture. He also brought an MRI from the referral, which doesn't show any evidence of AVM except for some barrow edema. So just to say a few words on neglected femoral neck fractures, based on the duration of delay, we can classify them into 4 groups. So acute are those who present within the first 24 to 48 hours. Late presenters are those who present within the first 3 weeks. And after the 3 weeks, we call them neglected. And the definition for non-union varies from literature, but some say that if they present after 3 to 6 months, we call them frank non-union. And I took this definition from this meta-analysis done by Zohari. So this is important because internal fixation device alone tend to have outcomes once the fracture is deemed neglected. So our options for treatment in those cases would be either an arthroplasty or head preservation. We usually go for arthroplasty in the elderly patient with poor bone stock. For this younger patient, we preferred one of the head salvage surgeries with good track record, which is a proximal femur osteotomy. So among the options for the proximal femur osteotomy, we choose the POWL, most popular valgus intertrochanteric osteotomy. And this is based on the principle that the weight-bearing forces across the hip 16 degrees from the vertical plane, which makes it 25 degrees from the anatomic axis. And if the fracture line is perpendicular to this resultant weight-bearing axis, then all the forces are going to be compressile. But if the POWL angle is above this ideal angle of 25, then shear forces dominate, redisplacing our fracture and increasing the risk for non-union. So his whole concept of the osteotomy is trying to change this POWL angle that we have toward that of an ideal angle through lateral closing wedge of the arm. So the plot for this technique is many literature reports a high union rate, north of 90%. It can also concomitantly help us improve leg length discrepancy, as well as restoring our neck shaft axis. Pre-collapse AVN is not a contraindication, which makes it an attractive. But the point would be with a higher degree of valgus correction, that can shorten our abductor lever arms, since we're bringing the tip of the GP closer to the center of rotation of our femoral head. And if we do not plan well, there may be some residual limb lengthening. So far as the implant choices go, the classic teaching is to use the blade tip. But for most of the young trainees, we tend to find it technically challenging. So we prefer the DHS option, which also have some reported added advantage, such as supplying your non-union site with autogenous graft with reaming and the option of either static or dynamic compression. As far as the single angle versus double angle debate goes, nowadays it's preferable to go for a single angle device because you will find the medialization of your shaft and stretching of the medial side of your knee ligament with these devices. And this, it doesn't also alter the mechanical axis. If THA done, it's going to be technically less difficult. As far as the level of the osteotomy is concerned, we prefer to do it through the intertrochanteric area because it has the reliable healing rate. And since it doesn't alter the proximal femur anatomy as much as your subtrochanteric osteotomy does, it is favored. As far as your wedge, you can take a full wedge, half wedge, or no wedge. Some good results have been reported even with a no wedge technique, as described by Gavaskar, he applied it subtrochanteric. So for our planning, we calculated for two things: the size of the wedge we'd like to take and our ideal pin insertion angle. So for our wedge angle, basically what we did was we draw our anatomical axis of the femur and then calculated the resultant axis, and then we draw a perpendicular line to the resultant axis, and the angle attended by the perpendicular line and that of our fracture line is going to give us our correction angle. Another way of doing this would be just to take a perpendicular line to your femoral anatomic axis and then draw your fracture line axis. That will give you your current power angle, and then you will need to subtract 25 from this number to get your calculated correction. And then for your pin insertion angle, what is recommended is to just subtract your implant angle from the wedge angle. And then you need to make sure that you do not result in excessive bulges, because wedge osteotomy, about 70% have been associated with AVN. Nowadays, there are even some people who recommend under correction when your wedge angle is north of 30. And you also need to make sure that your valgus correction at the end of your procedure should be within 50% of the contralateral neck shaft angle. And since we do not have this wedge resection template in CHOP, the height of our wedge we need to calculate for, and we use this formula from deformity correction, the rule of 57, where it's correlated 1 degree to 1 millimeter. If we have a radius of 57, from the imaging that we had, we can calculate the width of the bone at the area of our osteotomy to be 45. And
hi, Alazar. I'm sorry to interrupt. It's a little hard to hear you. Is there a way of moving the microphone so we can hear your voice a little better?
Yeah. How about now? I'm a little bit closer, I think.
That's much better. Thank you.
Yeah. Okay. So this formula will help us determine the height of the base of our wedge. So once we have all of this, we can go through our operative steps. So what we did is we used the traction table, and we first brought our fracture out to length using the Whitman technique. And once we locked the foot to the foot plate, we placed 2K wires for provisional fixation as well as the rotational wires. And then we placed our guide wire and DHS screw in our predetermined pin insertion angle. And then for our two osteotomy cuts, the proximal one is going to be a transverse osteotomy at the level of the LT, just centimeter below the DHS, so that we do not create, iatrogenic fracture. And then we made our second oblique equal to our calculated corrected angle or our wedge angle. And then after taking the wedge, we abducted the distal segment, and we introduced the lateral corner of the proximal fragment into the medullary canal of the distal fragment, so that increased stability is there. And then we released our traction. We brought the shaft to the plate, and then we, after determining the valgus correction, we inserted cortical screws in compression mode, try to close our osteotomy gap. So these were our last fluoro controls, which shows the restoration of the neck shaft angle, and also a center placement on both AP and lateral. So for our post-op protocol, we kept the patient on total weight bearing with bilateral crutches for 6 weeks. And then we started him on partial weight bearing for another 6 weeks. And at the 3 months follow-up, we saw adequate healing of our osteotomy site, and we initiated weight bearing as tolerated. DVT prophylaxis was initiated 12 hours post-procedure and continued per our institution protocol. We saw the patient at 2 weeks, 6 weeks, 3 months, 6 months, and 1 year. So at 3 months, you can see a complete consolidation across the osteotomy site. There is still the fracture line present along the fracture neck non-union. At 6 months, both of them have almost completely consolidated. But we can see the presence of coxa magna, probably due to some varus malreduction in trap. So current status, this is a photo the patient actually took at his home and sent it to me. He said that he can comfortably weight bear, but he has this mild to moderate left groin pain, which is worse, particularly with deep squatting and prolonged walking. He said that he can ambulate without support at home, but he uses crutch for outdoor activities. I told him at our OPD, and when I tell him to squat, he cheats on the operative side. He cannot make a full hip flexion, which is prevented by this anterior hip pain. He already had some gait problems prior to his fall, so I'm not sure how to assess this, but I can see that the operated limb has a slightly external rotated foot progression angle. When we assess the phase of the gait, we can also say that the stance phase is markedly reduced on the operated extremity. If we see him at the back, we can also appreciate bilateral equinus. He also has some hip adduction and internal rotation. So some home methods would be, as a rule, in a young patient, we should go for head salvage. VTO requires careful planning and templating, and good results have been seen with it. Much more important to my case presentation, even in a case of a neglected femur neck fracture, precise anatomic reduction in all planes is a must, because it can help you prevent future femoral acetabular impingement. And also a creation of rotational deformities through the osteotomy can be avoided by using 2 parallel K-wires, just proximal and distal to your cuts as reference. I'd like to acknowledge the attending in charge, Dr. Mohammad Yirga, for letting me present this case. Thank you.
That's great, Alazar. Thank you. Can you go back to the X-rays so that we can have those up for the discussion?
Yep.
Yeah, just go to the pre-op one, sure. Dave, do you want to be first, giving some comments on this case?
Sure. Yeah, I think another great case. Just I think the emphasis on the importance of preoperative planning and templating can't be overemphasized for these cases. But yeah, I think you did a really nice job. You know, creating a plan and executing that plan. You know, I think I mentioned on the last case a little bit the idea of how much correction is needed. I think I'd be curious what the other faculty think about that. This notion of having to always correct to the 25-degree angle can create a lot of deformity. And so some under correction is something to think about. Another comment, I haven't ever done this with a DHS. So I think one of the challenges maybe that you would have with a DHS that you can control more with a blade. With a blade, you can predict a little bit the amount of lateralization of the femur that you're going to get by the length of the blade you use, and that's part of your kind of preoperative templating. I would imagine that's maybe a little bit more difficult with a sliding hip screw. So maybe some of the surgeons who have experience with the sliding hip screw DHS could comment on how they deal with that and template for that. But great case.
Sammy, from the Ethiopian side, can you make any comments about blade plate versus DHS and the preferences there among your other colleagues and the residents?
Yeah. Yeah, so I like to use DHS as well in these cases. So unlike other cases where you are very adamant about tip apex distance, in these cases where you are basically converting the vertical fracture into a horizontal nature, the tip apex distance is not as critical, and you can actually get away with a much more wider tip apex distance. And that freedom, in addition to the rotation control that you can get with the addition of the not the rotation, the bone graft effect that you can get from the hole that you create might give you a better thing. So the only added thing that I do is whenever I use DHS, I also add the rotation screw before doing any sort of screw placement in these cases. But my preferred choice of fixation is also DHS actually. No, this specific case is, I think, a good example that DHS might be a better choice. I have done late presenting neck fractures, open reduction and internal fixations as well. As long as I don't have AVN, I have done both trochanteric osteotomy as well as intertrochosteotomies. And my choice depends on whether they have any remnant enough neck lengths. In cases when they have remnant enough neck lengths, I just use open reduction, remove the fibrous tissue and refresh the fracture edges and put screws. I use the anterior approach for those. And then when in the case like this where basically the neck seems to be eaten up, it will be better to use trochanteric osteotomy for a couple of things. One of the things is the length compensation can be gained by the osteotomy as well, but in general my choice is DHS.
We have a couple questions, good questions in the chat. The first about the use of bone graft, fibular strut in particular, in these types of cases. And then another couple questions about the role of advanced imaging prior to planning these cases.
So, for me, and I don't use the fibular graft here. I think the main issue here is, if you can get the mechanics lined up well, there is no added benefit of, fibular bone graft. To the most part, you are trying to get a primary healing, basically. And, bone graft will not be an adjunct to your primary healing principle. So, if I do opening and if there is, a gap, maybe, but otherwise, if we think of any strap bone graft, fibula, it will be autologous. Obviously, we don't have any option of bone bank here.
I thought the point that you were making earlier, Sammy, about refreshing a fracture was really good, and that's also one of the questions in the chat. Alazar, is that something you did in this case? Did you refresh the fracture site at all, or did you count on sort of the reaming with the DHS screw to do that job for you?
Yeah, we did not refresh. We just used the reamer to refresh the fracture site.
Any thoughts on that from the faculty? Yeah, go ahead, Sammy.
Yeah, so I don't refresh it when I'm doing a osteotomy. It will be too much exposure. I think it will be too aggressive. I mean, to be honest, I have not seen intertroch fracture not unite when for this cases. I have seen them develop a avascular necrosis. I have seen them develop, this sort of, cam impingement where they end up in arthritis later on. But I have not seen and then union out of it.
And then there's a couple of questions in the Q&A that I thought would be really good to answer live. Dr. Milkias, one of our faculty from a previous course, asked the question about reaming technique while using the DHS reamer. Dr. Milkias, maybe you want to ask that question just to clarify, because I'm not entirely sure. And then there's also the question here about future total hip replacement, the potential for total hip replacement. Now, I think, Alazar, you mentioned that the subtrochanteric osteotomy is more difficult in the future because it changes the architecture of the proximal femur more compared to the intertrochanteric osteotomy. Any comments from the faculty? Maybe Mark or K-Rod, Brian could comment a little bit on that.
Yeah, I think intertrochanteric level creates less of a problem for ultimate total hip arthroplasty. One comment about the suggestion about freshening the non-union site, it's absolutely not necessary. There's an attempt at healing there. It's fibrous tissue that's just trying to become bone. It just needs a little compression. So by changing the angle and converting it to compression, it heals relatively reliably.
Brian, any comments? No, okay. Dr. Milkias, I see there are a couple of questions from you. I'm wondering if you just maybe want to ask them yourself and provide your commentary, because I know that you probably do a lot of these cases yourself.
Okay, thank you so much, Kiran, for giving me the chance. And my question were about the reaming technique while we are using DHS. Some technique probably after reaming the hole, probably reversing the DHS rotation probably would leave the bone graft there as it is, so that probably it might have some advantage of a bone graft to the non-union site. And I have seen also some centers using an impacted bone grafting furthermore to fill up the osteoporotic spaces on the femur head. So probably if we cannot do that, I mean, reversing the DHS rotation probably would leave the bone grafts there as it is rather than taking it away. That was my one point. The other is, I don't know the faculties. There are situations where we cannot assure whether there is a vein or not. Let's say there might be some screws inserted, and then MRI would not be an ideal modality to rule out whether the head is alive or not. So on those cases, would you still go for surgery with the osteotomy? I mean, not making sure whether the head is alive or not, or would you have to do MRI removing the implants and then going for your definitive surgery? Thank you.
Yeah, if I could comment, Kieran, on that. The classic article, in my view, on intertrochanteric osteotomies for neck non-unions is from Rennie Marty. I think it's 1989 in the British JBJS, back when there used to be a British JBJS. There were about 50% of the cases that had some avascular changes, and the functional outcomes, even with avascular changes, were not that much different than those without. So I don't think there's a place for MRI in terms of planning. The functional outcomes seem to be quite good, even with avascular changes. I could comment some more about the biologic issues, but avascular changes don't change the planning, in my view, for a established non-union of a femoral neck fracture.
Yeah, thank you so much, sir.
K-Rod, any comments from your side?
I agree, you know, and if you think about where the ABN changes usually happen when there's some early ABN, it's really high in the sphericity of the neck. So when you're correcting, putting this into some valgus, you're actually moving the ABN and the contact point a little bit more lateral, which might be helpful too. In terms of the question of something that got me thinking as I was reading the chat, the issue of DHS versus blade, you know, and overcorrecting with the DHS. The advantage the blade gives you is it doesn't shorten as much, right? So when I've done the DHSs, I've tended to overcorrect, almost planning ahead that I was gonna get some neck shortening. And I don't know if that made sense or not, but it seemed like a reasonable thing to factor in, not only your correction acutely, but how it might evolve as the fracture settles.
Any comments from any of the other faculty on that? Or we could just have final comments actually on this case, since we're getting close to the end of time here.
Yeah, I'll just make one last comment about the DHS, which it's in terms of availability, at least in our settings, it's weird, but we have more DHS than blade plates. And so that's kind of the arguments of doing that. But there are, you know, you have to be very careful on how you put it and where you're putting it, especially if you're not doing it with C-arm, because I've had GT fractures and fractures extended up and you know, trying to do that osteotomy, flip it up on valgus, and then you have like kind of open book type of fixation because your screw's not exactly 100% in centered in the head. So just be careful of which you're not gonna necessarily have with a blade plate, because you know it's less aggressive, as Dr. Shankowski mentioned. And so my thought is that whatever you're doing, just be thoughtful of, you know, you're planning, pre-op planning, but where you put your screws. And you know, if you can do it with C-arm, that would be wonderful. But if you can't, just be careful of your actual maneuvers doing those osteotomies.
There's a nice question here just to end things, perhaps. What are the options for a neglected subcapital neck where you have like a really, really small neck length? So you're really just trying to get all the way into the head. I assume both a blade and a DHS could work in that as long as you get adequate length with your with either the blade or with the screw. Is that right?
Yeah, I think that's right, Kieran. But you can also do a trochanteric osteotomy and advance it to help improve the biomechanics of the hip. And with a DHS, if you put provisional stabilization with your guide wire, then do the trochanteric osteotomy, move it distally, then use the rongeur to create the little channel for where the barrel for the sliding hip screw goes. That can work very well. And then you tension band wire around the trochanter with your derotational screw to go through that trochanteric fragment.
Very nice. All right, Haile, do you want to maybe we can just run through last comments from all of the faculty, and then we'll wrap things up. Any other comments, Dave, Brian, Sammy?
So I guess in both the cases, we have not seen a derotation screw being used, but that's what I routinely use. I don't know about the experience of those who have done DHS, because with reaming, you can actually, flip everything, around, and you can do more damage. So I strongly recommend to use a good derotation screw before actually doing your reaming. I don't know. We can hear the comments from the other faculty about it.
Agree completely. Derotational screw always.
Yeah, absolutely agree with that. Yeah, I just wanted to thank all the presenters for these great cases. I think really impressive cases. For these valgus osteotomies, I think that my closing thought would just be, it keeps getting said over and over, but preoperative planning, these are cases for me where the tracing paper and stuff still comes out. It's really helpful to really think through these, know exactly what's going to happen when you make these cuts, where your implants are going to sit. The more you plan, the smoother these cases go. But yeah, really thanks everyone for sharing these great cases.
Yeah. Yeah, thank you. Sorry, I had to I had to drive, so I didn't want to interrupt everyone. But very, very good case, and I think the trochanteric osteotomy is a very good tool at our disposal, and especially in resource-limited settings where we don't have access to, early surgery, and sometimes the option of hemia joint replacement, we don't have them. So this is a really very, very good tool at our disposal, and I think based on these presentations, it's quite safe to use both DHS and angular blood plate. And I totally agree that, especially with subcapital fractures with very small fragments, the rotation screws really, really helps. Thank you.
And I wanted just to thank all the participants and the faculty and also the organizers. The quality of these sessions is just fantastic, and for folks like me who have a Western suburban type of practice, seeing some of the complications and the difficulties that come up with cases like this is not something that I have much experience on. So I find this very educational, and thank you so much.
Excellent.
Thanks, Kira. Yeah,
Thank
go
you.
ahead, Haile. Sorry.
I was just going to say thank you, everyone. This was another really great session. And Kieran, I can just hand it over to you to close out.
Sure. Yeah, thanks, Haile and Shravya, for organizing, and to the entire HEOC team, especially for Teja, Shravya, Nikhil, Sam, for all the hard work that you guys did. Thank you to all the participants, and thank you to all the faculty. Next slide, please, Haile. Just wanted to say that for all of these courses, all of these live sessions, we've had pre-session and post-session surveys that are very helpful. So the pre-session surveys, you can give us feedback on the lectures that have been recorded and the articles that we've sent out, which are part of the curriculum to prepare for these live sessions. Many people have already done the pre-session survey, so thank you for that. Here is a QR code to get access to the post-session survey, and we can post that in the chat right now if you prefer to click on that. And if you complete the pre-session and the post-session survey for all 3 sessions, which you can also go back and watch in the recordings after the fact, we'd be very happy to give you a certificate of participation saying that you participated in this course. And we really do appreciate the feedback. That's such a very helpful thing for us as we prepare these conferences for you. Next slide, please, Haile. I'd also just say, thank you to all the people who've joined us on our WhatsApp community. These are a whole bunch of QR codes. You can scan any of these, really, and they'll get you into the global orthopedics community that is growing on WhatsApp. Especially the Lower Extremity Surgery Global is a great place for sharing cases and advice. Pierre-Marie has been, and Brian have been very, very active on those channels, sharing cases, giving advice, and I'm certainly learning a lot. So if you liked what you heard today and you want to learn more from these excellent faculty, please do join the conversation, and let's keep the conversation going. Thanks, Haile. Next slide. Also, stay tuned. At HGOC, we're really committed to trying to make education free and high quality for everybody around the world who is taking care of poor and vulnerable patients using limited resources. So all of our programming will be, as you've just seen, focusing on cases from limited resource settings with faculty from diverse practice backgrounds who can provide commentary from high and low resource environments, giving tips and tricks and feedback in a very kind of conversational way, with lots of questions and comments coming in from all the participants, all of you who joined us today. So our next conference will be in May. We're going to take a little bit of a break as we prepare for that one. It'll be focused on spine. And so we'll have some really excellent cases, mainly focusing on cervical myelopathy. This will be our second year running the spine conference. So we really look forward to that. There'll be 2 days. Look out for a registration link. And if you are part of our email list, you're part of our WhatsApp community, we will send those registration links out through those channels. Next slide, please, Haile. This is my final slide here, just saying again, thank you. Thank you to all of you for joining us today, and for those of you who joined us for all 3 sessions, whether you're watching this as a recording or you're here live with us right now. Thank you so much. Please do send us your questions, your comments. We're always trying to make these conferences better, more useful, and practical for all of you. If there's any topics you'd like us to address, any ways that we can make this more useful to you, please do let us know. Here are the links again for the pre and the post-conference surveys. And I think I'll just leave this slide up for a little bit while people sort of say their final goodbyes and log off. So thank you everybody so much. Thank you all. Really had an amazing time today. Thanks.
Thank you all, and bye.
Thank you.
Thank you very much.
Thank you, everyone.